Healthcare transformation. A couple of simple words that over the years have meant different things in healthcare. Initially, it may have meant the introduction of HMOs, PPOs, pay for performance. May have meant Lean, Six Sigma, clinical pathways, care coordination. Today, it very likely means the shift from fee-for-service to value-based care models. Some would argue that this healthcare transformation that we're currently undergoing across the world is the largest transformation we've seen in almost 5 decades. Now, this transformational shift, this move from a fee-for-service to value-based care models, is being done in a variety of ways through reformation. Some organizations look at it in terms of regulatory reformation. So, how am I doing against my physician quality reporting, my AHRQ, my hospital value-based purchasing? How am I doing against my HEDIS scores, my HCAP scores? Others are looking at it in terms of whole new business models. So Affordable Care Act has brought about things like accountable care organizations, patient-centered medical homes, population health management. All of these means or methods of reformation could be as simple as the move from ICD-9 to ICD-10, and as an organization leveraging the improved specificity to better care coordination collaboration around my patient treatment. At the end of the day, no matter where your organization is in terms of this reformation, this move from fee-for-service to value-based care, all of it comes with a complexity, with a cost associated to it. At the very tip, just the management of these regulatory analytic measures, the ways that we define success, PQRS and NQF have a one-to-one overlap. So as my physicians have been monitoring against physician quality, my hospital has been monitoring against national quality, I need to understand that these have a one-to-one overlap in a lot of these scores. I also need to understand that hospital value-based purchasing leverages a lot of the NQF measures. And oh yeah, by the way, AHRQ has a one-to-one overlap with a lot of the NQF measures, which we just discussed relate back to the PQRS. And these all have a goal of improving outcomes, lowering the cost of delivery, which leads us right into patient-centered medical home business models. And patient-centered medical home leverages a lot of the population health management criteria analytics, which ties right back into the newfound TLA called Accountable Care Organizations, or ACO, which directly relate back to patient-centered medical homes. So before you know it, these hundreds, if not thousands of different analytic measures in success, performance, have to be effectively communicated not only across my 4 walls, but across the constituents, the consumers outside of my 4 walls as well, even my customers. As I look at the definition of one particular measure, which looks at my effective treatment of my coronary artery disease patients, and this is one example, I need to also understand that my hospitals may be measuring against already NQF 66. Likewise, my physicians have been measuring against PQRS 118. At the very least, all of these are interrelated and they're identical scores, whether it's from my home health system, whether it's from my hospital, or whether it's part of my accountable care organization. I need to be able to relate and have everybody on the same page so that I can affect my performance. The definition, the numerator-denominator, has complexity in and of itself. As each one of these, NQF, PQRS, ACO, may have a slight variance, for the most part they're all the same. But I have to have a way to manage the numerator-denominator definition so that everybody understands where this score, this analytic measure is coming from. I also have to understand that I may get this information that fills this numerator denominator from a variety of sources. My diagnosis may come from my claims system. My LVEF injection may come from my electronic medical record. If I'm prescribing ACE inhibitors or ARB therapy, that may come from my outpatient physician management system. And then likewise, I may get, whether or not they're an indexed admission, from diabetic registries. This all needs to take into consideration that with new accountable care, coordinated care models, it may come from hospital system A, it may come from my partner, hospital system B, or my payer. And likewise, it will definitely come from my home health system as well. If we look at readmit measures, the one single way that we can effectively change readmit rates is by leveraging the outpatient experience. So in reality, when I take a step back, I have to have a way to communicate across my organization and my extended organization how I am effectively performing. And this analysis, these analytic measures, numerators, denominators, need to have a way to communicate that so that we're all on the same page. It doesn't stop there though, because as I said, this data is going to come from clinical, operational, financial, and it's going to be historical and transactional because it's not just episodic, but it's longitudinal. So I need to know 6-12 months history, not just 6 days or 6 weeks. And likewise, Hospital System A has Epic, Allscripts, SSI, and Lawson. Hospital System B has Cerner, Athena, SSI, and SAP. And oh yeah, my home health system's not quite as advanced. They do have Embion as a clearinghouse, but there are also a lot of Access databases in Excel. So we all understand, and we've known for a long time, there's a data integration requirement to effectively report against these measures. But you also have to take into consideration that Hospital System A has made the move to ICD-10 as a way to define diagnosis. They're also LOINC, whereas Hospital System B is still ICD-9 and they're SNOMED. And oh yeah, by the way, my home health system, my physician management system, well, they're not ICD-9, 10 at all. They're HCPCS and CPT. So I don't just have a data integration, but I need to have a data interoperability capability. It's only at the ability to get at the data and then normalize it to make it interoperable that I can really report as an organization how I'm doing in this move from a fee-for-service to a value-based care transformation. And let's look at the very bottom of the problem, and that again it's longitudinal and it spans across clinical, operational, financial data. So I'm going to have data coming from claims systems, from financial supply chain systems, and it's not just going to be inside of my four walls, but it's going to be outside of my four walls, from my home health system, from my partners. So I have to be able to master the right patient, the right doctor, the right facility, coordinate all of that in the right language, and then have that in a place where I can access that information, the right data model, and look at it in a coordinated journey from, some would say, cradle to grave, but not just episodic, but longitudinal patient experience across clinical, operational, financial data, all mastered into one enterprise model. So when you take a step back and you look at the complexity of move from a fee-for-service to a value-based care model, it is actually not as simple as putting up an ACO Measure 33 and trying to map it to all the data. The complexity could exist a lot deeper. And in order to really evaluate how you're going to perform in the new world and effectively make a difference in this value-based care model, you have to consider the complexity. But the complexity is not insurmountable. At Information Builders, we saw this coming. We've been helping organizations get there for the last several years. And different organizations are at different points in this move, this transformational shift. So part of what we work with, you as an organization, is where are you and how do we map into it and where can we help out? Where do we fill the gaps? At some level, you're at the very tip. So the variability to map to our back-end data is key. Having the ability to define all of these measures and how I'm performing as an organization analytically. Look at things like my ACO, MU, PQRS, NQF, AHRQ. We do that out of the box for you. We've predefined the numerators, the denominators, so that we can map to your back-end systems. This represents time to market and reusability across your organization out of the box to see how you're performing. Are you going up? Are you going down? Then you can ask the questions against your corporate strategy of how you're performing and communicate that effectively, so that if I want to focus in on treatment, better treatment of my cardiac disease patients, what are the 5 measures, 5 analytic scores, and then more importantly, what are the numerators, denominators? You have to be able to communicate this back, because it's not just as showing a pretty dashboard, but you have to be able to know where the data is coming from, have that lineage to take you back to show you how it ties back in, why we're measuring it, how we're measuring it, who owns that measure, so that effectively you communicate it to that pretty dashboard. And out of the box, I can tell as an organization how I'm performing against ACO measure 33, or NQF measure 66, or PQRS measure 118. Everybody's on the same page. At Butler Health, we've been doing this for years. They had a back-end Meditech, a lot of third-party reporting tools. They couldn't satisfy the MU guidelines, and they were having difficulty meeting their pay-for-performance objectives, one of their first transformational journeys. By leveraging our software, they were able to meet the government requirements, impact their reimbursement rates, and do things as simple as improving their emergency department throughput. Some organizations are here. Other organizations have somewhat addressed this, but they're dealing with the interoperability, the integration question. So, great. Now I've got a whole other entity that I'm dealing with outside of my 4 walls that I've got to get data into a usable fashion so that I can effectively report against my accountable care measures. So not only do I have to have the ability to integrate HL7, batch data, FTP data, but I also now have to need NCPDP EDI data, where I get my claims information from. So at Information Builders, we give you the capability to get at all this data, but not just get at the data, but make it interoperable. Take it from SNOMED to LOINC, HCPCS to CPT, normalize it so that it's actionable, it's interoperable. And as you deal with not only your 4 walls, but other 4 walls, this is going to be core to your success in the move from a fee-for-service to a value-based care coordinated, accountable model. The ability to not just get at the data, but to normalize it so that it's interoperable. In Lehigh Valley, they saw this. They saw this capability, and they were able to actually leverage the ability to normalize and analyze the data more effectively, easier, once they got it to a clean and interoperable fashion. However, once you get the data clean, once you ensure you get at the data, again, it's a longitudinal view. So I have to have, and it's not just a longitudinal view inside of my 4 walls, it's a longitudinal view that spans across these coordinated care chains now. So I have to have capabilities to govern data across multiple business stewards within my own organization as well as my extended organization. So the concept or understanding of a patient that exists within my 4 walls and outside of my 4 walls, a provider that may be part of my organization or may be part of my coordinated care chain, likewise an employee facility. I have to master those concepts, and then once I get all of this clean and I understand the business stewards and how all the rules come together, I have to provide ways to maintain, to make sure that it stays clean across all of the systems so that I don't go back to this interoperable or uninteroperable state. So at Mount Sinai, we were leveraged just for the simplistic purpose of a master patient index. The ability to cross-correlate and create a single view, we were able to achieve in a few months. So now that Mount Sinai can effectively improve care, reduce their cost of delivery, and meet things like their meaningful use compliance. So when you take all of these capabilities, the ability to do performance management, the ability to create data integration, interoperability, the ability to master a provider, a concept of facility, and store all this other information, we created an out-of-the-box application called OmniPatient. OmniPatient represents the move from a fragmented to an integrated accountable care. We can take information from multiple sources inside your four walls, outside your four walls, whether it's HL7, batch, NCPDP, EDI. We can master that and normalize that into one language and then stick that into a repository underneath Steve Counsel, the patient, the doctor, the facility that represents my single version of truth, and then surface that back out to my downstream applications, my analytics systems, my portals, so that I can deliver information to the appropriate users so that analytically they can see how they're performing and ask the questions of why, how, what, when. So it may just be as simple as looking at the information as it relates together, as it comes in. It may be as complex as looking clinical, operational, financial data, doing population health management for my ACO, my patient-centered medical care home collaborative. But effectively what OmniPatient does is it combines the ability to do performance management, communicate and collaborate across my organization, outside of my organization, the ability to integrate data from multiple back-end systems, normalize it into one language so it's surfaceable under one single mastered view, to create a single version of truth to effectively improve outcomes while delivering the cost of delivery, to help organizations move from a fee-for-service to a value-based care model. The idea is out of the box an application that gives you the ability to govern, deliver, and present actionable data so that you can move from fee-for-service to value-based care transformation. And again, we're not reinventing the wheel here. This is what we're doing in other organizations. We're helping Memorial Health System and other healthcare organizations like it, leveraging the OmniPatient application to do this move from a fragmented to an integrated accountable care organization. So let us come out, talk to you about where you are as an organization. We can identify the gaps, find out where, at what point in the application you can leverage part of the process, and help you make the move from a fragmented to an integrated accountable care organization.